Hello everybody, today we are going to talk about miscellaneous pathologies. Let's start with subarachnoid hemorrhage and aneurysms. So what is subarachnoid hemorrhage? Subarachnoid hemorrhage is defined as blood in the subarachnoid space. This means that the blood is between the arachnoid matter and the pia matter. The most common cause of subarachnoid hemorrhage is trauma. Non-traumatic subarachnoid hemorrhage is considered spontaneous, and the most common cause of spontaneous or non-traumatic subarachnoid hemorrhage is ruptured aneurysm. The peak age for aneurysmal subarachnoid hemorrhage is between 55 and 60 years of age. Of those patients with spontaneous subarachnoid hemorrhage due to aneurysmal rupture, 15% of patients they will die before reaching the hospital, and unfortunately 50% will die in the first 2 weeks. Rebleeding from the aneurysm is the major cause of morbidity and mortality. Now, what are the common etiologies of subarachnoid hemorrhage? As we mentioned before, trauma is the most common cause of subarachnoid hemorrhage. Ruptured intracranial aneurysm is the most common cause of non-traumatic spontaneous subarachnoid hemorrhage. Bleeding from a cerebral arteriovenous malformation is the second most common cause of spontaneous subarachnoid hemorrhage. Other causes include vasculitis, tumors, and cerebral artery dissection. Now, what are the risk factors for developing an aneurysmal subarachnoid hemorrhage, or for a patient to have an aneurysm? Family history of aneurysmal subarachnoid hemorrhage was one of the most common risk factors to have an aneurysm. Smoking and hypertension also are important risk factors to have an aneurysm. Adding to that, alcohol abuse and patients with polycystic kidney disease are at risk for developing also multiple intracranial aneurysms. Now, how do patients with spontaneous subarachnoid hemorrhage present? Classically, these patients present with sudden severe headache, and what the patient describes is this headache is the most that he has ever experienced in his life. Other symptoms in patients with spontaneous subarachnoid hemorrhage is vomiting, photophobia, focal cranial nerve deficit. For example, patients with posterior communicating artery aneurysm might have an ipsilateral oculomotor nerve deficit. Also, seizures is a common presentation, and lastly, decreased consciousness. Now, on examination, patients might have neck stiffness, neck rigidity, positive Brudzinski sign, and positive Kernig's sign. Their blood pressure might be high, either due to pain or due to increased intracranial pressure. Focal energetical deficit, as we said before, decrease in the level of consciousness, decrease in the Glasgow scale, or coma even. And sometimes these patients might have ocular hemorrhages. Now, how to diagnose patients with suspected spontaneous subarachnoid hemorrhage? The gold standard is a non-contrast brain CT scan. If this CT scan is done and it showed no subarachnoid hemorrhage, but you still have a high suspicion of subarachnoid hemorrhage, lumbar puncture is done. And why the lumbar puncture is done? The idea behind doing lumbar puncture is to detect RBCs in the CSF. After that, after confirming the diagnosis of subarachnoid hemorrhage, the next step is to identify the source of the subarachnoid hemorrhage. And to do that, you should scan for the blood vessels, the arteries. And this is done either by doing CT angiography, MR angiography, or conventional angiography. On your left-hand side, you can see an axial non-contrast CT scan brain tissue window. Here, as you can see, there are hyperdense streaks inside the gyri in the subarachnoid hemorrhage on the left side. And in the interhemispheric sulcus. And this is how subarachnoid hemorrhage looks like on CT scan. On the other scan, this is also an contrast axial CT scan brain tissue window. As you can see there, subarachnoid hemorrhage, which appears hyperdense on CT scan, is present bilaterally and in the interhemispheric sulcus. Our next topic is chronic subdural hematoma. Chronic subdural hematoma is the accumulation of chronic blood in the subdural space between the dural mater and the arachnoid mater. Chronic subdural hematoma generally occur in elderly patients as they have a decreased brain tissue mass and prominent subdural space. The average the average age of patients presenting with chronic subdural hematoma is around 63 years. 50% of patients presenting with chronic subdural hematoma, they have a history of head injury, and this injury mostly is trivial, such as hitting an edge of a window or the ceiling of a car. Now, what are the risk factors for chronic subdural hematoma? As we said, being an old age patient per se is a risk factor for developing chronic subdural hematoma. Alcohol abuse, seizures or history of epilepsy, patients with CSF shunts, either ventriculoperitoneal shunt or ventricular arterial shunt or other CSF shunt procedures. If the patient has a coagulopathy, either congenital coagulopathy or patients who are on anticoagulation. And the last thing is patients who are at risk for falls. For example, patients who have a past medical history of strokes and they've got hemiplegia and difficulty in walking with risk of recurrent falls. So these are the most common risk factors for chronic subdural hematoma. Now, what is the pathophysiology of chronic subdural hematomas? As we said before, almost 50% of patients, they have a history of trivial head injury. So chronic subdural hematomas, mostly they start as an acute subdural hematoma. And this acute subdural hematoma most commonly will be small and the patient will has no or minimal symptoms. Now, this acute blood within the subdural space, it will evoke an inflammatory response around the clot itself. Within days, the fibroblasts invade the clot, forming new membranes. These membranes later on will have new capillaries, and with the action of fibroblasts and fibrinolysis, liquefaction of the blood clot will happen. Now, the fibrin degradation of the clot, this will inhibit hemostasis, and by that, the risk of bleeding from the new capillaries of the membrane will be high. And with the action of the fibroblasts and the inhibition of hemostasis, with the risk of bleeding from the fragile new capillaries, and with the high osmolality of the liquefied hematoma, this will lead to increase in the size of the subdural hematoma in the next few days or weeks. Now, how do patients with chronic subdural hematoma present? Usually, patients they present with a slowly progressive headache, confusion, dysarthria or language difficulty. They might present also with TIA-like symptoms, seizures, and as the size of the hematoma increases, they might present with hemiplegia or even coma. Now, the appearance of chronic subdural hematoma on CT scan. As it is chronic, so the density of the blood in the subdural space will be low. So this is the first thing to know, that chronic subdural hematoma will appear hypodense on CT scan. Now let's have a look at the CT scans that is in front of you. So on your left hand side, this is an axial non-contrast CT scan. Okay, there is a left frontoparieto-occipital, mainly hypodense lesion, extraaxial, similar in shape, most likely representing a chronic subdural hematoma. Now, as you know that after mentioning all the characteristics of the extraaxial lesion and measuring the anterior posterior diameter, the maximal thickness, and the size of the lesion, you should also measure the midline shift. The other picture is for the same patient, where it showed that in this cut, the maximal thickness and the mass effect is more than on the left scan. Now, what are the indications for surgery in patients with chronic subdural hematoma? First of all, symptomatic lesions. So if a patient presents with any of the previously mentioned symptoms and signs, you do a CT scan and you think that the chronic subdural hematoma is responsible for the patient's symptoms and signs, so this is an indication for surgery. Any chronic subdural hematoma with a maximal thickness more than 10 millimeter is an indication for surgery, no matter what, if the patient is symptomatic or not. The third indication for surgery is progressive increase in the size on serial images. For example, if a patient presents to you in the outpatient clinic or in the emergency department, and on CT scan there was a small rim of chronic subdural hematoma with a maximal thickness of 4 millimeters, for example, and the patient is asymptomatic or having a mild headache, and on follow-up CT scan, for example, that is done after 1 or 2 weeks, you see that this hematoma is increasing in size, but the patient is still asymptomatic or the maximum thickness is still less than 10 millimeter. So this is an indication for surgery. Now, just to know, what are the surgical options for chronic subdural hematoma? First one and the most commonly used operation is bare hole and evacuation of the chronic subdural hematoma and irrigation. Second option is what is called a twist craniostomy. And the last surgical option is craniotomy. And this is reserved mostly for patients with recurrent chronic subdural hematoma. So this is just a demonstration of how a bare hole looks like. So what you see here is small skin incision of the scalp with dissection of the periosteum, and the hole that you see there is what a bare hole looks like. There we open the dura in a slit-like incision, and after that the chronic subdural hematoma starts to evacuate. Now let's go and talk about entrapment neuropathies, and we will discuss two common pathologies, which are carpal tunnel syndrome and ulnar neuropathy at the level of the elbow. So carpal tunnel syndrome is one of the most common compression neuropathies, and it involves the median nerve in the breast area. How do patients present with carpal tunnel syndrome? Most likely they present with numbness and tingling in the hand, in the area of median nerve, innervation, and the thumb, index, middle finger, and the lateral half of the ring finger. Most commonly, this tingling is worse at the night, and this will awaken the patient from sleep. Now, what are the signs of carpal tunnel syndrome? Decreased pinprick over the area that is shadowed in the picture on your right hand. Tunnel sign will be positive in 60% of patients with carpal tunnel syndrome, failing sign in 80% of patients. So this leads us to a conclusion that nerve conduction study is the gold standard investigation for diagnosis of carpal tunnel syndrome. Now this is the tunnel test. You just tap with your fingers over the area of the flexor retinaculum, which overlies the median nerve, and this will evoke the tingling sensation or the numbness in the area mentioned before. And this is failing sign. Failing sign, you ask the patient to do breast flexion in this position, as you can see in this picture, and hold that position for around 1 minute. This will also evoke the tingling sensation that the patient experiences mostly during the night. Now, there are some common etiologies in patients with carpal tunnel syndrome. One of the most common etiology is repetitive job trauma. For example, patients who have repetitive trauma at the wrist, for example, carpenters, people who where their job include repetitive flexion of the fingers. This is considered a common etiology that is associated with carpal tunnel syndrome. Obesity also is a common etiology, pregnancy, and hypothyroidism. And think always of hypothyroidism whenever you see a patient with bilateral carpal tunnel syndrome. Now, what is the treatment for carpal tunnel syndrome? It really depends on the symptoms and the findings of nerve conduction study, and if the patient is having any muscle weakness or muscle atrophy at the thinner area. So if there is no muscle weakness or no muscle atrophy, non-surgical treatment is the first option, and this includes non-steroidal anti-inflammatory drugs and keeping the hand and the rest on in a neutral position. And this is done by asking the patient to wear a cast that is shown on your on this slide. And this is really works for most patients with mild carpal tunnel syndrome. Also, don't ever forget to treat underlying etiology. For example, if the patient is having hypothyroidism, treating the hypothyroidism will help in the treatment of carpal tunnel syndrome. For example, pregnant patients with carpal tunnel syndrome with mild cases after delivery, most of these patients will have decrease in symptoms of carpal tunnel syndrome. Now, in cases which present with severe carpal tunnel syndrome or with muscle weakness or thinner muscle atrophy, or in patients with mild or moderate carpal tunnel syndrome who failed after non-surgical treatment, surgery is the option. And as you can see there on the slide, this is how the wound of the carpal tunnel syndrome surgery is located. Now, getting to the next topic, which is the cubital tunnel syndrome, which is entrapment of the ulnar nerve at or just distal to the elbow. Why is this common? This is common because the elbow is one of the most vulnerable points where the ulnar nerve passes in that area. Here, the nerve is superficial, fixed, and it crosses the joint. Mostly, cubital tunnel syndrome is idiopathic, or it might be related to elbow injury, for example, in cases of fracture of the lateral condyle of the humerus. How do these patients present? Typically, they present with discomfort, pain, numbness, tingling, mainly in the little finger and in the medial or the ulnar half of the ring finger. Also, they might have elbow pain and hand weakness. A treatment of cubital tunnel syndrome is almost the same or similar to carpal tunnel syndrome. You start with non-surgical management in mild cases and go to surgical treatment in severe cases or in cases who fail to have relief of symptoms after non-surgical treatment. Now, why is it important to know about carpal tunnel syndrome and cubital tunnel syndrome? Because carpal tunnel syndrome, it is one of the most differential diagnosis pathologies in patients with C6 or C7 radiculopathies, and cubital tunnel syndrome or ulnar entrapment. Also, it is one of the most common differential diagnoses of C8 and lower cervical radiculopathy, mainly C8 radiculopathy and T1. Now, our last topic today is the idiopathic intracranial hypertension. It is also called pseudotumor cerebri or benign intracranial hypertension. Now, what is idiopathic intracranial hypertension? From its name, so it's increased intracranial hypertension with no underlying pathology. So it is a diagnosis of exclusion. Now, how do patients with idiopathic intracranial hypertension or pseudotumor cerebri present? They present with symptoms of increased intracranial pressure. Most commonly, headache and visual problems. And the vision problems is due to papilledema. So, papilledema and symptomatic intracranial pressure with more than 20 centimeter water, with the absence of any intracranial mass or infection. This will lead us to the diagnosis of idiopathic intracranial hypertension. Now, some authors, they include dural sinus thrombosis in the definition of idiopathic intracranial hypertension. And some authors, they exclude the dural sinus thrombosis as a criteria for diagnosis of idiopathic intracranial hypertension. And what I mean by that is when the patient presents with headache and visual disturbances, and after doing fundoscopy, you find that the patient is having papilledema, and you do the MRI and the MRV. If you find venous sinus thrombosis, you can diagnose the patient as either having a dural venous thrombosis, dural sinus thrombosis, or you can say that this patient is having an idiopathic intracranial hypertension. What I believe is, or what most authors believe, is that whenever you have a patient with dural sinus thrombosis, this is the diagnosis, rather than diagnosing the patient with idiopathic intracranial hypertension. Now, what is the importance about idiopathic intracranial hypertension? For us doctors, in these cases, our nightmare and the most serious complication of this disease is blindness. And after knowing that this blindness, which usually is permanent, is preventable as long as you diagnose the patient and you treat him properly, you can save his vision. Now, more common patients, idiopathic intracranial hypertension is more commonly found in obese females in their 30s, in the third decade of their life, than other general population. Now, what are the other signs of idiopathic intracranial hypertension beside the papilledema? Is abducens nerve palsy, which is a false localizing sign, and visual field defects. Now, what are the associated conditions that is related to idiopathic intracranial hypertension? As we said before, obesity is a risk factor. Hypoparathyroidism is also a risk factor. Some medications, I will mention only 3 of the common medications that you see in your practical life. Hypervitaminosis, or vitamin A levels of higher than normal in patients who take vitamin A supplements. Also, tetracyclines and ciprofloxacin are medications associated with benign intracranial hypertension. Now, how you diagnose patients with benign intracranial hypertension? As we said before, you do an MRI of the brain with and without contrast. Add to that an MR venography, rule out sinus thrombosis, and if all of these MRIs are normal, do a lumbar puncture for the patient, measure what is called opening pressure, and if this is high with the presence of papilledema, this is how you diagnose patients with benign intracranial hypertension. The first step in treating those patients are medical treatment. So start with weight loss and a drug called Diamox, which is a carbonic anhydrase inhibitant, which acts as a medication to decrease the CSF production rate. Now, if this fails after you give the patient the maximal dose of Diamox, or the patient cannot tolerate the side effects of the Nemox, you go for surgery. Surgery, you have two options, and these options, it depends on the presentation of the patients. So if the patient presents with mainly visual disturbance and severe pupil edema, optic nerve sheath fenestration is a better option than CSF shunting. In patients who present with headache, severe headache rather than visual loss, CSF shunting may be better than optic nerve sheath fenestration. Okay, so here we end our topics today. Thank you. Please do not hesitate to ask any questions when we meet during the clinical round in the hospital. Thank you.